All right.
Terrific.
Ready to go? Okay, we're all set.
Perfect. My name is Steve Belcher. This is Dr. Neil Dunn. Give you guys an idea of our team, although you were sitting in here for it earlier. We have Bruce Geyer. Bruce has been in medical sales for over 20 years.
Over 20 years.
Yeah. And we have, I'm going to skip over your rod, to Alan Dunn, Neil's twin over there, who is another lawyer on our team. And we have Mr. Rod Martin, who was early stage PayPal and many other ventures that I'm sure he'd love to talk to you guys about. I'm the newest addition to the team. This team has gone out and recruited me. I've been in nuclear medicine, nuclear pharmacy for going on 20 years now, and so have a little expertise in this market space of where we're going. Well, we want to talk to you today in global pet imaging. We are not a new product, we're not a new device. What we are is a new service and a new offering to the marketplace, a new way to approach the marketplace. As we talked about earlier, the medical marketplace or the hospital marketplace is reeling right now. The hospitals are hoarding their capital. They are very risk averse right now, so we are not investing as we should in the doctors and hospitals, or doctors' offices in the hospitals, as we should in new technologies. And what we want to do is lower the barriers to create opportunities to get into new diagnostic, better, more specific, more sensitive studies than that are currently available. So I'll let you take it from there.
Thanks so much. So let's just start with what's the problem. And the problem is traditionally cardiac imaging tests lack accuracy. That means that we don't get good diagnoses and therefore not good treatments. Too many people get unnecessary catheterizations of their heart. Reimbursement for traditional cardiac screening nuclear tests is plummeting. So the doctors who used to get $1,200 a study now are getting $370 a study in the hospitals, on the order of the same sort of loss. Newer imaging technology does, however, require an intensive capital outlay. And he's mentioned, everybody's on the ropes, they're hunkered down because of the general anxiety in the face of healthcare reform right now. And the concern of will they be reimbursed? So what are our solutions for positron emission tomography imaging? That is low-cost, ready-made solutions for positron cameras, for PET CT fusion cameras, and for rubidium generators. More about rubidium in a minute. Rubidium is a specific heart agent. So why do we want to push PET, positron emission tomography, instead of SPECT, the traditional nuclear medicine studies for heart and bone and lots of other things? And the answer is superior imaging results. So we get better diagnoses, more accurate diagnoses, more rapidly. We can calculate cardiac blood flow using PET. Can't do that with SPECT, and that's an important thing to the cardiologist talking about cardiac reserve. Fewer equivocal results, and the images, it images well larger patients with a BMI that is generous, prosperous, if you will. And of course, women, their breasts attenuate these studies, so they have difficulty with the SPECT studies. That's not a problem with PET studies. So more accurate diagnoses. And I want to digress for a moment to tell two quick stories. Why PET instead of SPECT? And the answer is, so 10 days, 2 weeks ago, I had a SPECT study because I had an atypical chest pain. And I ended up with a study that was equivocal, and they weren't going to do any cardiac catheterization on me. Ended up going to a PET study, a center that offered PET scanning, not in my city, unfortunately, and got a PET study that showed I needed a cardiac catheterization. I needed an angioplasty. I had one Monday. I'm here before you guys now, feeling great. Modern medicine is terrific if we can get it to people properly and accurate diagnosis. And the second story comes from Steve.
Right. I know you can't tell from the shape I'm in, I look wonderful, but I've had 2 cardiac caths. The first one was fantastic. I needed it, but they didn't know what they were going to find when they got in there because of the accuracy of regular SPECT scanning. So the second time I had a cath, it was totally unnecessary. When I got in there, the cardiologist told me, "Whoa, you look better than you looked the first time we did it." Why am I here? Exactly. Which is very costly. So what we want to do is add value to the system. For $1,400–1,500 reimbursement versus $8,000–9,000 reimbursement for catheterization, the hospitals save money if they do more accurate tests. they run more efficiently. So that's whether it's hospitals, doctor's offices, clinics, whatever, you're going to run more efficiently if you do it this way. And for patient care, it took me 2 to 3 weeks to recover from the second cath. First cath, 2 days, I was fine. Second cath, it takes a toll on your body, right, Larry? So, just wanted to give you guys that little story there.
I think that value proposition also carries over to the payers. I sit on the advisory board for Blue Cross Blue Shield Florida, the largest insurance company, health insurance company in Florida, and they understand the value. They're coming to understand and reimburse better the value of these advanced imaging studies. So I thought the stories might give you a sense of why we're here. Fewer unneeded cardiac catheterizations, at least one we could have avoided. And also, there's less radiation exposure to the patients who are getting the test and the staff who's administering the test. And that's a big subject of concern these days in medicine. Now, we talked a little bit about the medical reasons to do it. Let's talk about the financial reasons behind it. Chalk River is a nuclear reactor, highly enriched uranium reactor, weapons-grade uranium reactor in Canada. It supplies 80% of the Western Hemisphere's technetium, which is what they use for spec studies of the heart. That reactor is closing in 2016, and it already has had a number of reliability problems where it's offline for 4 to 6 weeks at a time. The spec isotopes, therefore, the technetium isotopes, are facing huge disruption in the market in the near future. We're talking about 2 years, that's going away. And there are literally hundreds of thousands of the cameras that image this all over the country. So alternative sources of technetium-99 involve either low-enriched uranium reactors or some other complex things I won't get into. But the low-enriched uranium reactors generate at least 5 times as much nuclear waste per dose. So that's a problem too, and it's probably not a great long-term answer.
So we're also talking about hospitals moving straight to cath instead of doing the spec studies when they don't have the isotope. So
Don't have the isotope, gotta go out and get a cath. How many more caths you want?
None.
There's 14,000 spec cameras in the United States, to let you know. 14,000.
Lots of them. So the other thing that's interesting is that the reimbursement for positron emission tomography as opposed to spec, PET as opposed to spec, is much higher. It runs $1,400 roughly in the hospital, and about $1,360 in the doctor's offices, as opposed to $360 or $70 for spec. So there's reasons for the hospitals and doctors to move to that. It's the
financial
capital
motivation. Right.
So there are some new applications as well for positron emission tomography. Alzheimer's, you've all heard about scans for Alzheimer's. They're all being done with PET, not SPECT. Right? Cardiac MPI, that's the rubidium that we are so interested in. Prostate cancer is a new marker in the pipeline, should come out this year, that is specific dihydrotestosterone for the androgen receptor is going to be huge, change the world for prostate cancer. #1 cancer in men. Bone scans can be done with PET scan much more accurately, and scanning to response to monitor response to chemotherapy and radiation therapy. So what is Global PET going to do in this market? Since we don't produce cameras, we're going to grow the market for oncology and especially for cardiac myocardial perfusion imaging. Now, oncology is how I got into the business. I have a PET scanner and I was doing oncology scanning. Mr. Geyer actually came to my office and sold me on the idea, and it's turned out to work out very, very well. It's a highly professional way to do it for oncology. But the cardiac market is one that's critical and about to have a major shortage we can address.
Quickly, just to address so we're not all on clinical, so we know this is a business proposition. We're talking about the accuracy and the need for all this. Where is the business side of this? We are going to take what is now bulk sales and lack of commitment in the marketplace. No one wants to commit to PET cameras that are anywhere from 800,000 to 2 million. And no one wants to commit to the bulk product, which is rubidium. You have to sign up a year contract at a time, and it's $40,000 a month that you're committing to, whether you have patients or not. So what we want to do is introduce this in a unit dose marketplace where doctors can buy this per patient, unit dose per patient, make it affordable. And then we want to be able to help them with cameras, whether it be lease, whether it be a trial where we move a mobile camera in and help them figure out how many patients they're going to do a day to be able to do their pro formas and everything else.
So like pay by the drink, so to speak.
That's correct.
Yeah.
That's correct.
And it's a pass-through cost for them. So they just pass on the cost of what the drug was.
And as you'll see further in the presentation, I know we'll try to speed it up, but with new government regulations do not allow doctors to profit from this. So it can be a pass-through cost for them. We can get in where they're not worried about drug costs. What they're worried about is how much money they're going to make on the technical fee of the PET scan. So at $1,400 versus the $370 for a less accurate scan, they're getting paid more profitability to the physician office, and they have less risk.
And better answers. So you mentioned that the doctors can't profit on this, and that's important. We can, however. And it is the straight pass-through on doctor's office. Now, I want to say doctor's offices and hospitals work a little different with Medicare, and the hospitals are addressed in the next slide. So these offices are now being notified they cannot profit, and they must be very careful about how they're, with existing generators, how they have to handle them. And of course, we mentioned PET scanning has better reimbursement. Now, hospital users are called Part A. So that doctors are Part B Medicare. This is Part A, hospitals. And they're under a different payment system, HOPS. And the way that works is we can't actually charge for the isotope, so we joint venture with the hospital. We essentially divide up the cost of it and provide the machinery and the generator. They provide the room and the technicians, and we also provide the service agreement. And we'll joint venture on that and basically divide the gross income. And that works out to actually be very profitable to the hospital and obviously to Global PET Scanning as well.
To give you an idea, just to jump in quickly, to give you an idea of the opportunity here and how risk-averse hospitals are right now, I live in Mobile, Alabama. The biggest hospital in that area is Mobile Infirmary. It's the 4th largest employer in the state. PET scanning has been out since 2001. They just bought their first PET scanner 2 months ago. Amazing. $600 million in assets in the hospital. They just bought it.
So we got to get past this initial.
What's the reason? They didn't see it as a priority, or they thought it was too expensive, or what?
I think there's been a lot of advances in the isotopes just recently that have really made it compelling. And in oncology, at this point, if the hospitals don't have a PET scanner, they're not a serious oncology center.
Yeah, why go there? I mean, just like it's practicing medicine, you want to go to the right doctor at the right facility, right? Okay.
So we're going to provide state-of-the-art scanners, generators, lowest risk rate, lease rates on the market, full contracts of service, and the reason for that is because people tend to save money on service and they get downtime. We don't want downtime. We're partners with them. We assume any existing generators, if they'd like, give them a liquidity event. We reduce their problems with the RAC audits. RAC audits are Recovery Audit Committee, kind of terrible if you're in the medical business. They come in and recoup a lot of money from your business. And we offer reduced lease payments on rubidium if, in fact, there is an interruption in rubidium supply.
Are you guys selling to the hospitals or to the doctors?
Both.
Or both? Okay.
Both. Yeah, we want to have an answer. I think we have good answers for both groups, and the hospitals are also very tight with their capital. So what else do we do? Not just 2 minutes. We provide consulting services to their clients so they maximize their pre-authorization rates. Work with the payers to show the value proposition. That's one of the things I do with Blue Cross, and consult with them on their billing practices, and offer experienced readings. So not everybody, not all radiologists or cardiologists are used to reading these studies, and we can provide that those readings remotely or train for those cardiologists to learn how to read. And obviously, we want to work to ensure a supply of isotopes going forward in the future, and that's another thing that Global does that we can talk about offline. There is a new, highly prized rubidium generator about to come on the market, and it will compete with the only existing one that is there now. We're happy to work with the ones that are there now, that company, and the new company. And indeed, some of the sites will be constrained by long-term leases. But we do think that the new generator has some significant advantages in terms of radiation exposure to the staff and also safety, actually, for the patients. And that's what I want to say to start with, and we're happy to talk and answer questions.
Okay, let's do some one